A patient sits across from her oncologist and hears the best possible news following a breast cancer diagnosis. Her biological tests indicate a tumor that is slow-growing and highly responsive to therapy, providing a prognosis that suggests a routine recovery. But within 5 years, the clinical outcome diverges from these laboratory predictions. The cancer returns with a high degree of aggression, bypassing typical sites of spread to appear in distant, unexpected organs, like the spinal cord or the urinary bladder. This graph tracks a clinical reality unchanged in half a century. While survival rates for standard breast cancers have steadily risen since the 1970s, the line for invasive lobular carcinoma, or ILC, remains flat, with a long-term survival rate of 60%. This document, published in 2026 by Dr. Laszlo Tabar and his research team, investigates this exact contradiction. They present evidence that ILC is an actively deceptive malignancy that operates outside the detection capabilities of our modern medical systems. The tragedy of ILC lies in how it exploits the specific blind spots of modern oncology. It masks its lethal nature from the moment it forms, remaining hidden until medical intervention is no longer viable. Routine mammography is designed to catch solid objects. Standard breast tumors typically grow into distinct solid masses, or they leave behind calcium deposits that appear as bright white clusters on an X-ray. The classic form of ILC produces neither of these markers. It develops without a central lump and without microcalcifications, making it difficult to identify using the visual detection methods radiologists rely on most. Instead of a solid sphere, the cancer presents as an extensive structural distortion, stretching between the chest wall and the areola, as seen here in these bilateral mammograms. This hidden web acts like an internal anchor. In this horizontal projection, the malignancy causes a tent-like retraction, physically pulling the underlying pectoral major muscle inward. To understand how the tumor achieves this structural camouflage without forming a mass, we have to look at the disease at the microscopic level. On this wide-view histopathology slide, these cancer cells creep through healthy adipose tissue in a diffuse spiderweb-like structure. Notice the black lines marking the concave contours. This indicates the tumor weaves into the healthy tissue rather than pushing outward. At maximum magnification, the mechanics of this infiltration are visible. Dark cancer cells march in perfectly aligned single-file lines, moving between bands of newly formed fibrous tissue. Because its physical structure is a creeping web rather than a hard knot, it bypasses screening tools designed to find solid objects. Traditional mammography remains ineffective unless radiologists are trained to search for these subtle architectural clues. Once doctors locate and biopsy this hidden tissue, they rely on chemical biomarkers to determine the necessary intensity of treatment. In the lab, ILC produces a very specific chemical signature. It tests positive for estrogen and progesterone receptors, negative for the HER2 protein, and shows a low cell proliferation index. This data illustrates a clinical mismatch. For almost any other type of breast cancer, these biological markers suggest a highly treatable tumor. But for ILC, that expected outcome is statistically unrelated to the actual survival rate. The chemical results are accurate, but the predicted behavior of the disease is not. This biological profile masks the disease's behavior, leading oncologists towards conservative treatments for a cancer that is already spreading. These biological markers offer a false sense of security. They provide a roadmap for management that may delay the aggressive intervention required to save the patient's life. The consequences of this delayed intervention are illustrated in a second clinical case study, where a 55-year-old woman arrived at a hospital experiencing abdominal pain and abnormal uterine bleeding. Expecting to treat a routine gynecological issue, her doctors performed a surgical biopsy of her uterine cervix, but the pathology slides revealed a result doctors did not expect. The malignant tissue found deep inside her cervix was metastatic breast cancer. Standard breast cancers typically spread to the lungs, liver, or brain. ILC frequently bypasses those organs to colonize the soft tissues of the lesser pelvis, as seen in these slides showing breast cancer metastases inside a urinary bladder. This migration pattern creates a significant obstacle for treatment. When secondary tumors appear in these uncommon locations, they are difficult to trace. back to a primary tumor in the breast that may still be invisible on a mammogram. By spreading through the body in a way that traditional malignancies do not, ILC demonstrates that it operates under a different set of biological rules than standard breast cancers. Why does this specific cancer break the structural, biological, and geographic rules established by modern oncology? The answer may lie in how the disease is classified. The World Health Organization currently defines ILC as an epithelial tumor, assuming it begins in the milk-producing cells of the breast. Dr. Tabar's research counters this. Through cell culture data and clinical evidence, his team demonstrates that the established understanding of where this cancer originates is likely incorrect. Their findings suggest this cancer does not start in epithelial cells, but instead originates from hybrid, pluripotent mesenchymal stem cells. This different point of origin explains why the disease behaves so unusually. Epithelial cells are designed to stick together in sheets or clusters, which is why standard cancers form solid lumps. Mesenchymal cells, however, are the structural builders of the body, programmed to be mobile and form connective networks. Because the cancer inherits these traits, it weaves through the breast in single files rather than clumping, and it has a natural affinity for the soft connective tissues of the pelvis. To reflect this biology, the authors propose a new terminology, breast cancer of mesenchymal stem cell origin, or BCMO. Adopting this model provides the clinical foundation needed to manage the disease. It tells radiologists to search for distortions instead of lumps, and it warns oncologists that a favorable biomarker profile is a discrepancy that should not be used to delay aggressive treatment.